colleagues here. Um, I think thanks for organizing the session and talking about equity. As during the keynote address, also we hear that if there are inequality and if there will be digital divide, then AI will going to amplify the inequality. Now, the answer is also in AI. If I say three or four key things, A stands for maybe accessibility, affordability, accountability, and I stands for inclusive design in terms of that. So yeah, I think one of the key aspect is to have accessible system which can work in hard to reach areas. Again, thanks for quoting some of the interventions during national COVID vaccination drive when we were designing CoVIN, and it was supposed to be utilized by 1.4 billion beneficiaries, including those who are living in hard to reach areas, which offline environment. Can they access? Can they register? Is there a mechanism to do that? That is the accessibility aspect. The second aspect is the affordability. Do every citizen, do every beneficiary, or even with respect to the healthcare workers, around 1 million ASHA workers and 200,000 ANMs, can they access these applications where we are planning to incorporate AI? So the designing aspect must be such that the affordability criteria is maintained, both with respect to the user interface, but also with respect to the digital literacy and the inclusivity aspect. I think I can keep on talking about it, but I got a reality check when somebody said that you are catering 1.4 billion population through 1 million healthcare workers, and there are 22 kind of disabilities. Are you sure your applications like Covin, even can access if somebody is colorblind, if somebody is not able to uh, view things properly, if there are some other issues, how can we make it inclusive? I can
Thank
stop
you.
here.
Yeah,
Within time.
we'll come to
Sure.
the particular intervention a little later. Dr. Mona Dugal, you're the director of National Institute of Research in Digital Health and Data Sciences. So your perspective about AI and health equity issues, please.
Thank you. Hello. Yeah, thank you for the question. I think when we talk about health equity and digital divide, it's very important how we actually look at it and look at the problem. So some of the things will come from the field experience that we have actually had. The first was when we are actually looking at some of the solutions, we forget that we are very excited to bring in the solution, but we forget about the entire continuum. And we might just go into the field, and this has been the problem that we've been seeing. People are excited about a particular problem. They'll say, okay, we can screen cancer, we can screen this, but do you really have the entire continuum? It's just not that you screen the person and then you leave the person. You have to make sure that the entire referral system is in place. So equity is in the, of course, we all know that probably there are certain people who will have better understanding of technology, and there are people who will be having less. So, for example, the elderly, certainly they are technologically challenged. And then you have women, they will probably, like in the rural areas or in the slum areas, if it's in the family, most likely the man of the family will have the smartphone and everything. So we will have those kind of challenges. But even if you're able to do those things specifically, but ensure that you have the entire referral system. So, for example, two or three studies that we have done in the field. One was the DR screening that we did. We are very successful in identifying DR, referable DR, in the field in a rural setting. There were like 60 people we identified. And to our surprise, when we went back to understand, like, okay, we referred them, we told them you can come to PGI, but we never had a retina specialist nearby. PGI was like 200 kilometers, and out of that, only one male person made it. And that person also never came back again because it was too far. It was not plausible for him to get back. Then, in fact, one of our physicians said, there's no point in telling the person if we do not have the entire referral. So, equity is not only that aspect that you are saying. Second studies that we are doing is more on the health education. So, one was around how you use the chatbots within the WhatsApp. It was a fairly successful implementation. But again, I think it required a lot of hand holding, but we had to make sure whatever knowledge that was being given to them had to be structured and validated. I think we were one of the first few that we actually, the papers that came out was around vaccine hesitancy, and we had the chatbots in like integrated within the chatbot within the WhatsApp, and any information that we had done was validated. But the reason it was successful was because the person who was actually leading it was a pediatrician. He was leading from the front and he already had a buy-in. When we took the entire system into the real world, it failed because we did not have motivated frontline health workers. So you have to see like how you are actually implementing in those things. Last is like the pragmatic trial we did for the integration of the like some of the systems that we had done. We realized although we say digital tools, simple counseling might be even better. Some of the things that we see may even not require the digital tools at that level, because what you require even for that equity, if you have certain things within that vicinity, if you do a good counseling, people will actually go. So we have to be very sure how we are going to be implementing at which level and how. It is just not because you have the digital tools and the AI, but where you do it, how you do it, and how you implement it, and all the continuum is there. So all those systems need to be in place.
Thank you,
Venkat.
madam. Thank
Yeah.
you. I think Abhimanyu covered on the innovation side and the scale side. I think you covered into the implementation plus the the component of evaluation that is critical. Thank you so much, Ms. Vinita. Madam, over to you from your experience on AI and health equity. How do you design the solutions that I
Yeah,
adopted?
so I think very important inputs have just been mentioned. From the practical experience, I know this is, the best practices will come later, but it's very important to understand that when we are building AI models, especially for health and looking at health equity, who are we really going to design this for? So the element of co-design here is very important. Now, when I say who are we going to really be designing this for, are there data sets already included? Are the data sets of the vulnerable population, of the remote area populations, of the gender biases included in the AI tools that we are going to look at for designing health equity? So that's the first important thing, the inclusive. Welcome. Inclusive design principles must include those data sets. I'll come to examples specifically later because I was involved in a very important initiative called the Edison Alliance or the World Economic Forum, which we implemented in Africa and India for resource-constrained and vulnerable populations. And we reached our target, you'll be happy to know, 1 year before, because we were able to triage and get those data sets into technology platforms to impact health. The second thing is the deployment strategies. Mona and Abhimanyu have both spoken about it. Deployment strategies would actually mean, are we focusing on scalable but low cost implementation models that will be able to integrate AI tools? And this has to be combined with digital literacy programs. What's the point of giving high-flying platforms either to the frontline workers or to the populations when, as you said, Mona, most of the women are deprived of even using those? So can we use instead say simple 2G platforms and large-scale LLM models? Again, on this, it's very important for us to be able to understand that whether it's Africa, whether it's India, we need multilingual interfaces.
Yeah.
So are we already approaching the co-design with those interfaces, which are not just relevant for the frontline workers, but equally relevant for the people we are going to impact? And